There you go. So just to be clear, my conflict, I have zero interest in the disc being successful or not, the M6 disc. My conflicts with Orthofix are primarily when this Matthew Scott Young wrote his paper, they put together a group of surgeons and basic scientists and total joint guys. Armin is in this group as well. And we meet fairly regularly. And I'll say over the last 6 months, we've probably looked at hundreds of x-rays, trying to get not only M6, trying to get a better understanding of this wear and osteolysis, which we'll talk about. And I've got reimbursed for the meetings we've participated in. So I have no real conflict in the success or failure of the disc, but I've got consulting fees from Orthofix, mostly for participating in their study group, which they've put together. Next slide. So, I mean, it's kind of funny. Let's be honest, guys. I mean, you can talk about form and function. I mean, we're taking basically a hip joint and putting it in the neck. It makes no biomechanic, kinematic, or physiologic sense any way you look at it. We got to do better than that. Next slide. So the M6, which I think people are aware of, is designed to closely mimic the natural disc. It has an annular structure with fibers weaved at 30 degrees, much like the normal annulus in a nuclear structure. And it's really designed not to look like a natural disc, but to physiologically behave like a natural disc. And we'll talk about that with the kinematics in a second. Next slide. So this is what it's important to think, because the issue isn't really arguing whether you need cushioning or not. It's really about kinematics, right? Because adjacent segment protection is going to be based on a kinematically sound disc. A disc that moves in a completely non-physiologic, non-functional way is unlikely to protect from adjacent segment disease, and certainly won't protect from same segment disease. So these are from Dr. Pat Warden, biomechanics in Chicago, and I've worked with Pat for 20 years. And this, in orange on this, is the normal kinematic signature. So on the x-axis, we have the going from extension to flexion. The y-axis is a range of motion. And you see in the orange graph, it's a very gentle curve. And the midline where the X and Y intercept is a neutral zone, which is sort of the sloppy zone in the spine. And if you destabilize a segment like you do a laminectomy, which we did years ago, you can see that the segment moves great. So if you look at flexion extension, you're patting yourself on the back. But in that neutral zone, essentially it goes from neutral to 8 degrees of motion in a nanosecond, completely non-physiologic. But it looks great if your end game is terminal flexion extension X-rays. So this is sort of the kinematic signature that's obviously important to incorporate into any technology to reach the goals of disc replacement. So next slide. So this is looking, and Pat's tested probably every disc on the market. There you see that nice gentle curve, flexion, extension, the M6. You can see it almost precisely in yellow follows the red dot of the normal segment kinematics. So that's what you'd like. You'd like it to function. It's not really about the cushioning. It's about that structure of the disc has graded resistance. So when you get to the neutral zone, the resistance increases because of the design of the disc, and you get that gradual transition, which is physiologic. Next slide. So the next slide is showing when you put a disc, in this case, it's C5-6, and all the other colors are the adjacent segments. And you see with a disc that moves physiologically like the M6, the adjacent segment kinematic signatures all look pretty close to their natural signature. So that's what you'd like. Normal signature at the operated level and the adjacent levels. Next slide. So this is like one of Scott's favorite ball and socket design. You see exactly what happens. And Dr. Pat calls it the slip and slide phenomenon. It doesn't move much, neutral zone, it flies over. And then it gets you very nice flexion extension, which is what we clinically measure. But everyone would agree that's a crappy motion pattern, putting abnormal stress on facets at the index level, and probably does it do anything bad to adjacent segments? Let's see the next slide. So this is that same kinematic signature where you see not only at the operate level, but the adjacent levels, because of this rapid motion in that sloppy neutral zone, see abnormal stresses. So it's clearly not just about saying, oh, we need a cushion. It's about a disc that provides normal or as close to normal kinematics we can get to protect this facet at the index level and adjacent level. Next slide. So everybody, I think, is familiar. And, this is about M6. There's no way to avoid it. It's the only viscoelastic disc that's widely used in the US. So you can ding me for being, calling out a disc, but it's really the only one we have. And I'm sure this is exactly what the talk Scott had in mind when he asked me to talk about this. So you can see it's the only disc that is on the market that has 6 independent degrees of freedom: axial compression, flexion, extension, lateral bending, translation, and axial rotation. So it's clearly, in terms of biomechanics, kinematics, a step up from putting a hip in our necks. Next slide. So I'm going to first talk about the IDE study, which I think Jack or Scott alluded to. So, it's a typical IDE study, and the details don't really matter because the study parameters, outcome parameters, inclusion, exclusion criteria were really identical to all the other IDE studies. So you can actually compare between them. So I'm not going to run through that. Everybody's pretty sophisticated about disc replacement now. This was done where, instead of randomizing, because by the time the study was done, it was impossible to randomize because there were so many commercialized discs. So they found such sites that loved doing ACDF, didn't believe in disc replacement. They just did disc replacement. Other sites they didn't believe in, they just did ACDF. Other sites that were disc sort of replacement sites, and they did disc replacement, but inclusion, exclusion criteria were identical. And then they got more ACDF controls from another IDE study where they bought data, but very much equivalent to all the other IDE study designs. Next slide. So the endpoints, as you know, on the slide on the left, are basically the FDA-defined endpoints: no serious AEs, no revision procedure at index level, maintenance or improved neurologic function, NDI improvement of at least 15 points. And to be considered an FDA success, you have to meet all 4 of those. And then obviously, much like all the other ID studies, we measured secondary endpoints like NBI, VAS, motion, etc., which clinically matter but weren't that important to the FDA. Next slide. So here's the sites, the ACDF, the M6 sites. There were 230 patients treated, randomized 2-to-1 M6 versus ACDF, and there you see sort of across the country sites. Next slide. So this is the NDIs. So both groups, Fusion in red, M6 in green, started at about 50, typical to these studies. And there you can see pretty quickly came down. And at each time point was statistically better in the M6 group, favored the M6. And then now, this is now the 5-year follow-up data for this cohort. We see a better NDI score at 5 years in the M6 versus the Fusion group. Next slide. Similarly, this is the NDI improvement from baseline, and there you see M6 in green, ACDF again in red. And you can see at each time point through year 1, 2, 3, 4, 5, the M6 is doing clinically better than the Fusion, and statistically better as well. Next slide. And important, there's no degradation as we get longer follow-up. If you think failures were happening, this would start degrading. Haven't seen that at all. VAS neck pain. To be clear, all these patients were enrolled primarily for radiculopathy, so this is not applicable to patients that come in with axial neck pain, this data. But obviously, as you all know, often these radiculopathy patients have significant neck pain, as this data would support. Pretty high neck pain scores. They went down from 7 to 2 point something very quickly. And again, the improvement maintained out to 5 years, again, favoring M6 over the Fusion at each time point, and really at 5 years, 0.6 out of 10 for the M6 group. So really good improvement in neck pain. And then shoulder arm pain, which is obviously the radiculopathy indicator. And again, as you'd expect, you do a good decompression, very good improvement in both groups, and statistically significant improvement favoring the viscoelastic M6 at each time point out to 5 years. And again, at 5 years, point under 1 for the arm pain in the M6 group. So that's a pretty compelling clinical outcomes. Next slide. So now look at the reoperations, and obviously these groups are followed closely. This is not anecdotally. I mean, every site has study coordinators and gets FDA audits. So it's not like we can be burying reoperations. So at 5 years, there was 5 subsequent surgeries in the M6 cohort. And there you see 3 of them involved removal of the implant. So the other 2 are usually foraminotomies for perhaps some radicular complaints. 2 were performed for persistent neck and arm pain. 1 was actually replaced by an M6, another ASTF, and only 1 was bone loss associated with confirmed periprosthetic joint infection. So really, at 5 years, which is reasonable follow-up, certainly not long-term follow-up, the issues of lysis have not been widely seen, or certainly not been clinically relevant. And yeah, I mean, to get to what Armin's point, at the last few meetings we've all been at, Rick Sasso's enrolled more than anyone in the IDE. Dom Corey did these in the pre-IDE study. And sort of show a hand, like none of them have revised one. So I get it. If you CT everyone, you'll see stuff. But in real world, that has not been our clinical experience. Next slide. So this also looks at the FDA data, subsequent, unfortunately, sort of Scott presented the 40 cases from TBI with a whatever revision rate. This is the big series, not 40 patients. So these are the IDE data, and there you see revisions at 5 years reported for all these other discs. And there you see it, M6 3.1, Pro Disc around 3, Prestige 3.9, pretty much the same. I mean, it's not like this is a huge blip in terms of everything that we've seen at 5 years in the tightly controlled IDE studies, where people are monitoring these patients arguably very closely, probably much more closely than we do in our clinical practice. Next slide. So concluding at least the IDE data, there are 2 benefits associated with M6, which resulted in FDA approval, are retained, maybe even look better at 5 years. We showed the scores, the pain scores for both groups. There are 5 subsequent surgery in the M6 group at 5 years compared to 11 ACDF group. Obviously, the ACDF group would be for pseudos mostly. And we continue to follow this. And I now have patients 8, 9 years. And just to correct you, Scott, the only revision I've done on an M6 was a patient for a pyogenic infection, like say he was actually a triathlete, Ironman. And he got some type of cancer in his abdomen. He was having all these abdominal procedures, got a swelling in the neck, and he had a staph pyogenic infection in his neck. And the disc was completely intact, but it was very difficult to get out, and I fused him. So that's the only revision I've personally done in this group. Next slide. So, and the other thing I think that's telling is this is probably one of the most widely implanted discs in the world. It's still, I think, one of the most widely used disc in Germany. And they've implanted 60,000 worldwide, 12,000 or more than 10 years. That's long follow-up, longer than ours, the US follow-up, and Matthew's follow-up. And so if the rates of 30% revision, I mean, even if people don't follow them in real world practice, I mean, that'd be a lot of revisions. That'd be like 4,000 discs that had been revised. I mean, we would hear about it. Like in Europe, they look at us like we're crazy. They're not seeing it. So there's clearly another side to what's been painted recently with this disc based on this real world experience. Yes, it's not prospective randomized data, but just based on the numbers. If there were 4,000 revised discs at 10 years, I don't think people would keep putting them in. We'd be hearing about it. Next slide. So let's talk about, so this is Matthew's patients. So Scott touched on them with about 34% revised for wear. We really don't have any data, and we've tried hard to get a lot of it from Matthew unsuccessfully. Like, we don't know what triggered revision. Did he find cysts and revise them? Were all these patients symptomatic? Most of them were like multi-levels, hybrids. I mean, we just don't know what it really means, given that we haven't seen this in the US. Next slide. And so we'll talk about osteolysis, and it's sort of, Scott touched on it, decrease in periprosthetic bone density. There are multiple causes: wear debris, micromotion, stress shielding, infection, and the clinical implications in disc are unknown. It's a radiographic finding that could be non-clinical, or implant loosening that could lead to failure. You wonder how many of these, you get it in your head, they're not doing well. You start CTing everyone. There's lysis. You start just revising everyone, and how many could have been monitored. Certainly, Josh Jacobs, who's a world-renowned wear guy in hips and knees, is on this panel I talked about. And the majority of cases in joints that have osteolysis are followed. They only revise them if there's significant year-over-year progression. So looking at them at one time point is probably not meaningful. Next slide. We don't have to go through this, just too complicated with my slide issues. So, and this is not really new. Here's a study from European Spine Journal, 14, looking at the literature, 14 studies, osteolysis in 46 patients reported. There you see it. And you see it commonly. In this particular series, I had 22 out of 46 prestige. So now, I mean, I'm not slamming prestige, but that's what the data says. And you got 10 out of 46 Matthew Scott Young's paper, a very sort of skewed small population, etc., going through all of the discs. So, you know, it's seen in all the discs, and it just depends. You know, someone who likely it's going to be in the literature, if someone who's done 40 and revised a lot, they're going to report it. But I think the bigger picture I talked about moments ago tells a different story. 4 articles out of these osteolysis type patients reported positive cultures P or C acne staph. Next slide. So just talk about particle media osteolysis, just keep going. So what does this all mean? So what happens is hit it again a couple of times, please. Hit it again and again and again. Yep. So go back one. Yep. So there you see the process. You know, you get some type of wear in the hip. It's usually the polyethylene from the acetabular component. The macrophages make all these cytokines, these that cause osteoclastic activity and bone resorption. And there you see on that hip x-ray, bony removal or disappearance around the stemma, so-called osteolysis. So that's sort of the typical osteolysis. Next slide. And yes, we've seen it. Here's an example of a disc where clearly this is not remodeling. This looks just like the osteolysis in the hip, and it certainly exists. Next slide. But there's other causes, inflammatory. Here you see this particular knee from Josh Jacobs, where there's a periprosthetic joint infection. You see below the tibial base plate in those corners, the bone melting away. Next slide. And then the issue of infection, and this is another, this is a study with M6 specifically, and same thing, you know, cases that got revised, delayed periprosthetic infection. There you see in all 3 cases, P. acnes was isolated. 2 of the 3, there was gross purulence. The 4th case in this series, they didn't look for P. acnes, so they didn't know if it was there or not. 2 were treated with ACDF, 2 left the M6 in sight and just washed it out. So this is like well-known stuff that we've seen with this disc, with other discs. Next slide. So here you see, this is well-known in hips, you know, stress-induced remodeling. And I think that's a lot of it. One of the images that got, I think, Scott popped up, we've seen hundreds of x-rays now in this group we're working. And very commonly, the area of the implant that's not, the area of the end plate that's not loaded. So for example, if the disc isn't all the way back, that back corner of the vertebral body will routinely sort of melt away. We see it with every disc we've looked at. And the same thing anteriorly, there'll be rounding of the anterior cortex remodels of the end plate if it's not loaded because the prosthesis sits behind it. So this is a well-known phenomenon. And I'm not saying all cases of osteolysis are this, but we need to be more critical and talk more about remodeling. That's biomechanics, stress phenomenon, not loosening, not osteolysis. And here you see very well known in hips, where you see the bone in what's called for the neurosurgeons, the calcar, which is the bone just where the arrow is. And you see how it melts away because it's not loaded. And it's actually not a rare occurrence. It happens pretty routinely in hip replacement, if I remember back 25 years ago to those days. And we see, next slide, hit it again, we see the same thing. There you see that sort of disappearing in the back of the vertebral body. And we CT some of these, and it's remodeling, you know, so you can't just call everything you see lysis. Next slide. And we've worked as this group, and we've just actually submitted some of this in Armin's part of this group. And we have Steve Kurtz and Josh Jacobs, who are total joint basic scientists, Todd Landman, Bay, a bunch of surgeons. Most of them have no deep or any relationship with orthofix. And we've sort of categorized these bone changes, and I'm not going to get into it tonight. We've got a whole category scale that we've gone through and had a million versions of, and done all the accuracy metrics to try and come up with the categories of changes that we talk a common language: end plate rounding, erosive changes with diffuse margins, with sclerotic margins, et cetera, et cetera. So a talk for another day, But I think it does us all a disservice just to say, M6 is doing this, and because we saw some stuff and we took out 10 of them and maybe half didn't really need to be removed. I think we need to be much more critical when we look at this. And I think if you look hard, you're going to see some of these findings in every disc we do. Next slide. So I'm not going to talk, I'm running late, like when do you intervene? I think the important thing is if you're suspicious, you're going to get a CT. We don't have a good way of looking for infection pre-op, right? The joint guys can aspirate joints, and now they've got all this DNA testing, looking for infection on the joints. They can do MRI stuff now where they look at soft tissue and can see infections. In the spine, we don't have any of those types of technology. So we're unfortunately stuck with going in there, probably taking out the disc and doing cultures. Usually, as I think Armin Scott said, the labs are typically normal, so they're not generally helpful. But I think, if you're concerned, close observation most of the time is the right answer, unless, there's migration or the patient's super symptomatic. And the stress shielding phenomenon, we've seen x-rays where you see it at 2 years and we see x-rays at 8 years and it looks exactly the same. And, the trigger might have been in that 2 x-ray, I got to operate. So clearly you got to follow them over time. And the progressive changes are the ones that really matter. Next slide. So let's not throw the baby out with the bathwater. The cases revised for lysis, some lysis because Matthew claims they're not infection, were mostly off-label. Over 12,000 discs with more than 10-year follow-up worldwide. We'd know if a third had failed. I would question Matthew, we haven't ever got this data. How many that he revised had symptoms, or how many was he worried he saw lysis and things would go to hell, so he revised them? Was it progressive? In joints, typically, if you see lysis, you follow it over time, years often with x-rays. So I think we need to understand all these things much better before we draw definitive conclusions. I'm not saying I certainly have all the answers, but I just think, piling on this makes no sense. As I think I've pointed out, we don't have enough understanding. It clearly hasn't been a US-wide problem. I mean, obviously, thousands of these have gone in the US and with longish follow-up of 8-10 years, getting to now OUS more than 10 years. So I think, just saying that there's a problem with the disc makes no sense. And I think arguably it's not about over-engineering, as Lisa appropriately pointed out. It's about trying to get the kinematics that matter. No one would argue not that the artificial disc should look like a normal disc. We don't care about that. But we'd certainly argue that it should behave like a normal disc if the primary advantage of disc replacement is adjacent segment protection. And none of us would look at that graph where the thing flies at 10 degrees in that neutral zone in a micron of time is a good thing. Next slide. So I would conclude that our experience in the US with viscoelastic disc, in particular M6, given that it's the only one out there, shows improved biomechanics, kinematics compared to ball and socket designs, unquestionably. We've seen very good clinical outcomes out to 5 years in the M6 in a very closely followed cohort. We're obviously now starting to gather 7 and 8 year data, and a cursory glance doesn't look very different, but obviously we'll need to do that in detail. I think we need to closely follow failure mechanisms of all disc replacements as more implants are used with extended indications. And I think we need to evolve to an evidence-based process to evaluate disc replacement failures in a rational treatment process rather than, these sort of sensational claims that don't really seem to bear out when you look at the data as a whole. So I'll end there, and I'm sure there'll be some arrows thrown my way from Texas. But yeah, I think that's where we're at. And sorry about my slide glitches.
Hey, Frank, this is Jens. So no arrows from Texas. A very thoughtful talk, and congratulations for assembling this study group. I have a simple question. So now that we have this large follow-up, questions have been raised about patient safety, and I'll leave that aside. I want to leapfrog to the actual premise that you identified in your kinematics aspect, and that is there actually something that shows us all that this is a superior device to the regular, as you call them, ball and socket configurations? Is there something that shows that this complex viscoelastic element actually has superiority in any adjacent segment diseases or patient outcomes compared to the more rigid non-cushioned devices?
Yeah, it's a good question. So we know for sure biomechanically it's superior, right? I mean, I just touched on the 2 slides. Pat Warden studied this for years, and it's not only flexion, extension, lateral bending, the center of rotation, any ball and socket is exactly the opposite. It puts in the superior versus the inferior end plate. So biomechanically, there's no question. Kinematically, it's a better disc. Yeah, there isn't really clinical data. I mean, we've done and others have, put all the FDA data together in graphs. And actually, I think Jack, in his going to the dark side days, presented at NAS graphs where he compared all the discs to one another. I think M6 looked pretty good. But, those are sort of artificial comparisons. So the real answer to your question is there's probably no clinical data that one clinically has better outcomes than another. And yeah, adjacent segment issues, it's sort of all over the place. I mean, mostly seems to be when you get to 7, 8, 10 years, about a third the rate of revision surgery in all discs versus fusion. But I don't know that we've teased out that anyone's better or not. So the answer to the question is we cannot make those claims for sure with any disc.
Frank, one concern that I have, it's a bit of a leap of faith to compare metal bone interface in a load-bearing, heavy weight-bearing synovial joint to a non-weight-bearing or minimally weight-bearing cervical disc in a dry area, and yet try to equate the radiographic changes. I'm just not sure that's fair, that we can do that. That number one. Number two, we can suffer through loss of calcar thickness or progressive intercortical lysis in a hip, unless the patient is incapacitated. You have the luxury to watch it, but to watch progressive changes in structural bone in the cervical spine where doing the wrong thing could be a catastrophic fracture and paralysis, are also, different consequences. And the third observation is then, it's troubling to me that we don't see those changes with discs that we've had much longer experience and much broader experience with.
So a couple of points. First, I'd say I don't know that I agree with you, Jack, about differentiating the hip because of the loads in the neck. I mean, they behave the same way. If that were true, why would we see osteophytes and bone spurs in the neck? It behaves just like a hip with arthritis, even though the loads are massively less. And the bone remodeling is not a made-up thing. I mean, we've looked at, and one of these days we're going to put it together and share. I mean, hundreds of discs. And if you look closely, and I never did before this, and I've been in, like, as you guys, we've been in, 3 or 4 IDE studies. And when we went back and looked at them, you see like remodeling, whenever the disc's not loaded, I mean, the end plate's not loaded, it remodels. I'm not saying all the cases of osteolysis are remodeling by any means, but I think we need to understand it better and differentiate the two. But that's a real thing. I mean, we see it on every disc. And if you look closely at your discs, whichever designs you've used, which I know many, you'll see that. I mean, we just our minds don't focus on it because it's like, yeah, whatever. And like the same thing, you see osteophytes years later, right? When the disc's mobile, there are cases because it moves, your body reacts just like a natural disc and you start redeveloping posterior osteophytes 10 years later because, that's what the body does when it moves in ways it shouldn't. So, yeah, so I think that analogy is not quite true. What was your third question? It was about
you haven't seen it the other discs.
I mean, we've looked at a lot of discs, and when you look hard enough, I'd be surprised if that's true. And that short one slide I threw up, these guys reported, and they'd seen it in almost every disc out there. So I think it's a real thing. And you asked about the fear of it. So first of all, I think that's true, which is why I emphasized if it's progressive, you'd be more aggressive, right? Like if you see at a point of time and a patient's asymptomatic, and even if it looks not so kosher, you're going to say, all right, I'm going to see you in 6 months or a year. And if it keeps getting worse, it might trigger you to operate. But we all say that. I mean, I don't know. I've never heard, maybe you guys have, of a case of catastrophic, like in the canal paralysis from this mechanism. I've heard of guys sticking in them canal with original surgery, blah, blah, blah. But I've never, we say that's the fear, and you get an x-ray and you get nervous. And there's certainly a time where you're going to go, I just don't want to take the risk, and you shouldn't. And it's not like we see that a bunch. I mean, even with all the failures that people have talked about, none of them present with paralysis. Even Matthew's series, they had neck pain and maybe some radiculopathy. None of them came in, with a disc in the canal because of the lysis. So I think it's a bit, sensational to use that as a reason to reoperate. But I agree with you. I think, to be fair, I think you should follow them. If it's progressive, it would certainly make me more inclined to want to operate. I 100% agree.
All right, my turn. 3 questions. Question number 1 is, given the European experience of follow-up, which can be very inconsistent, it kind of rings hollow that just because we haven't heard of it, how do you know there hasn't been 4,000 cases? Number 1. Question number 2 is, the largest series of artificial discs captured at a single site is TBI, with consistent indications for surgery and indications for revisions. So how would you account for the difference in percent revisions at our site? I mean, I think if there was, the whole purpose of registries is to detect early problems. So, again, it's not just one site, Australia, we've had the same experience. And then question number 3 is, where's the radiographic data on the IDE cohort, and why aren't we doing CT scans at 5 years or 7 years or whatever on the captured patients that we do have the multi-center trial information on?
Yeah, so I think, the first part, I agree. I mean, the 10,000 patients at 10 years is sort of not a study by any means, but, I think it's hard to really logically believe if 1 in 3 or whatever the numbers were getting revised at 10 years or failing. I mean, it's hard to imagine we wouldn't hear something about it. Someone there would be going, whoa, something ain't right. And there are guys in Europe, like Armin talked about at Eurospine, who have followed 100, 200 patients and not seen it. And I don't know why. I don't know. I've got no substantiated, or I've got my suspicions about the revisions, because you guys revised a bunch. You did, I think your series was 46 or something, 50 of the M6 in the ID, and Matthew had about the same. But I've done 100 or something, and Rick Sasso's done a few hundred, and Armin's done a ton. We haven't seen it. And even if you'd argue some of them might have osteolysis, and before we were aware of it, we didn't look. But we were seeing symptomatic patients that weren't doing well. Presumably, we'd image them and look further, and we're just not seeing that. So I don't know why there are differences. I mean, could it be a manufacturing batch issue? I have no idea. But I mean, it is strange. I mean, you guys obviously, if your data or Matthews was coming from people that are disc haters, I would view it very different. But both groups who are reporting it are like strong proponents of disc replacement. But I don't know why there are these pockets. I mean, I just don't know. I think you could argue we're missing lysis because we don't look. But if the patients were symptomatic, you'd think, if we were, I presume most of your patients were symptomatic that you revised. Admittedly, yours were mostly infections, which Matthew said his were not. That's we'd be seeing those if they're coming in with neck pain, radiculopathy. We'd image those patients and see big osteolytic holes, and we wouldn't ignore them. So I don't know. It's curious to me as well. I mean, I think it's real what you guys reported. I wonder if it's, and I don't know, batches. I saw John Sabozek in the back. Maybe he can talk to it. I don't know if you want industry in or not, but it is strange. I agree. And I don't think it's like, you looked harder, we don't look at it. I mean, I can tell you, and Armin is up next. He'll tell you, I mean, we've spent freaking hours studying these X-rays of discs. I can't stand it anymore. I'm so sick of it. And we see it with all discs when you look closely. But Armin, I don't know, you're there somewhere, comments, because we've been in this together for the last 9 months.
He has a microphone, and he'll show us a case. So great segue. Thanks for the intro. Frank, great lecture. I'll applaud you.
Thank you, Frank.